Started. So thank you for joining us today. We are celebrating the Alan M. Kaplan, MD Children's Neuroscience Invited Lectureship, which was established in honor of Dr. Alan Kaplan, who was the first pediatric neurologist in Arizona and a founding physician of Phoenix Children's. He was instrumental in building what we now know as the Barrow Neurological Institute at Phoenix Children's. For his 40-year career, he has helped support children and their families and has made an indelible mark on our hospital and our state. Each year, the lectureship celebrates Dr. Kaplan's legacy by inviting a distinguished neuroscientist to share their expertise and engage with our community of clinicians, learners, and researchers. Thank you, Dr. Kaplan. This year, it's my honor to introduce Dr. Lana as our recipient of the 2025 Alan M. Kaplan Children's Neuroscientist Invited Lecture. She is Chief Neuropsychologist and Director of the Neuropsychology Service at Children's Health, where she's also the co-director of the Pediatric Demyelinating Diseases Program. And she's here today to talk to us about neuropsychology's role in multidisciplinary care for demyelinating disorders. Dr. Harder is board certified in clinical neuropsychology, and she's one of a relatively few number of neuropsychologists who's also a board certified subspecialist in pediatric neuropsychology. She holds dual professor appointments of psychiatry and neurology at UT Southwestern Medical Center. And she has been instrumental in our field, not only for multidisciplinary care and demyelinating disorders, but also in teleneuropsychology. She started her work in teleneuropsychology prior to the pandemic. So when COVID happened, she was poised at the forefront and was asked to speak nationally at international conferences and really did lead our field into a new way of practicing neuropsychology. So I am honored to introduce Dr. Harder. Thank you for joining us today.
Well, thank you for that lovely introduction, and it is such an honor to be here for this lecture today. Thank you for having me. I am talking about a couple of topics that are some of my favorite to talk about. I think it's a little hard to hear. I want to make sure this is turned on. I'm seeing a signal from the back. And I will project also. Is this better? Yes. Awesome. Okay. All right. Well, as we get started, I do want to share disclosures that relate to some of the research that I'll share with you today. So some of that research funding was supported by the Children's Trust, the National MS Society, and Consano, which is a crowdfunding platform. I always like to start by acknowledging our patients and families with rare disorders. They're really the ones who have taught me what I know about working in this field. And so I like to start out by acknowledging them. So this is broken into 3 parts. I'm going to talk a little bit about demyelinating disorders. So you have a little bit of a framework for how we build multidisciplinary care for these patients. And then I want to talk about roles and opportunities for neuropsychologists, but I really believe that this pertains to all individuals and all team members when we bring a multidisciplinary team together. So for those of you who might not know, but I bet all of you do, neuropsychology really focuses on the science of the central nervous system as it relates to human behavior. That's the most concise way I could think of to say it. There's a lot that goes into it. We are known for our comprehensive evaluation batteries, but we do a lot of different things, and I hope to demonstrate that today. A lot of what we're looking at is really, cognition, behavior, emotion, quality of life, how various things like sleep and fatigue can show up and impact daily functioning. And we know a lot of these things end up being associated and overlapping. And one more thing I like to say as we set the stage for this discussion is, I wear the hats of researcher and clinician. And so we're going to talk about what we know from the literature, but I always want to underscore that of course, there's no one size fits all. So some of the things you hear about a given demyelinating disorder may or may not apply to the person in front of you. And that is exactly why we have tailored evaluations, creating tailored treatment plans for these patients. So let's jump in and have a quick refresher on the neuron. I know everyone is excited to do that. I am aware that we have a range of learners here today, but I did want to highlight this because it is central to how we're understanding demyelinating disorders. So thinking about the neuron, this basic component in the central nervous system, really critical for sending signals, allowing us to do things like talk, walk, interact, listen to this lecture today. And on the axon, I'm going to see if I can do some pointing here. On the axon, you'll see labeled a myelin sheath, and that's the insulator, the thing that allows these signals to transmit quickly and to send those signals. The signals could not go as fast or necessarily where they need to be without this. Here's an animation of that. On the left, you see the healthy nerve, and that signal is strong and moving through. When we have an attack on myelin, which is happening as a result of the immune system, we can see that we lose that strength of the signal, and it is compromised. And so that can start to produce our symptoms that we see in conditions like multiple sclerosis. So leukoencephalopathy refers to that destruction of the myelin sheath. And we can see that in lots of different areas, not just in demyelinating diseases. So can come up in trauma, infection, and other things. But what we want to do when we see these symptoms emerge and we've identified a demyelinating disorder is put out the fire. So there's this inflammation that's occurring, and acute treatment is really meant to stop that and to stop the damage that's occurring. Time is of the essence when this happens. I'm going to share with you some data about what happens when we don't get to this quickly. These are rare diseases, so it's not always at the top of the differential list when people are seeing them in acute care settings. Long-term, the goal is to keep these attacks from occurring, right? Because if we can do that, we can slow that accumulation to disability. We certainly want to address residual damage and manage the symptoms that the person is experiencing. The broad goal, of course, is to return function and prevent new attacks. Okay, here are some of the treatments used. I put an asterisk by steroids. Steroids can be a really helpful treatment. From a neuropsych perspective, we will not test a child that's been on steroids within 30 days because of the symptoms that it can cause as side effects that could affect cognition, mood, and other things. So, and this is something I've seen pretty consistently in the literature as well. If someone is on long-term steroids, of course, we will not withhold a service from them, but many times they're tapering off of steroids, and that's when we would avoid testing until we had a little time that could pass. Plasma exchange, IVIG, used in the acute care setting. And then over time, our disease-modifying therapies, which were only first approved by the FDA in the 90s, which is hard to believe. Those are the drugs, and they've multiplied. They're in different, they're oral, they're through infusion, injectables. When I started in the clinic almost 17 years ago, there were a lot of injectables, and we now have a lot of other options to offer our kids, which is awesome. And then rehab therapies are really critical in the short and the long term for our patients. Fortunately, mortality rates are low, but these conditions can be associated with significant disability. And at this point, we don't have any known cure, but we have some really great treatments and exciting treatments under investigation, including some stem cell treatments, remyelinating agents meant to repair damage. So it's an exciting time, I think, to be in this area and to be watching how those investigations go. I alluded to this a moment ago. So we talked about time is of the essence when there is a demyelinating disorder presenting itself. And we surveyed almost 500 members of a patient advocacy organization at that time known as the Transverse Myelitis Association. So we learned that over half presented to more of an acute care, emergency department, urgent care. And the diagnosis was incorrect for about a quarter of those surveyed. One thing that stood out to me is a third experienced a delay of greater than 7 days to treatment from the initial presentation. And as I mentioned, that's problematic because that damage continues. So we know that, the need for treatment is it's urgent. And when we don't get it, as we saw in this study, most worsened if they were sent home. So I wanted to share with you kind of a snapshot of the diagnoses that we focus on in our clinic in Dallas. So our focus is CNS demyelinating disorders in children. These are rare. Multiple sclerosis is not itself a rare condition, but in children it is. And so we are seeing these kids as a team and working to address the variety of needs that they bring. I do want to say a few words about differential diagnosis. I don't envy my colleagues who are trying to figure out what's going on when these patients present, because there's a lot of overlap. And you can see in this table, areas affected are overlapping. They can produce almost any neurologic symptom depending on where the damage is. And so there's a lot of detective work that goes on to figure out what is happening. So, of course, the clinical phenotype, the symptoms are really important. You can see, again, that this could be a whole host of symptoms, again, depending on where the damage has taken place. And we're fortunate in this day and age to have MRI brain and spinal cord. We didn't always have that in our images here. This is actually a sagittal view of the brain of a 14-year-old with MS. And you can see some of the lesions that are perpendicular to corpus callosum, and those are called Dawson fingers, and they're actually pretty specific to MS. And so looking at images, also looking for biomarkers. And so the CSF will show oligoclonal banding, and I think it's about 85% of those with MS. And then we've also learned a lot from the work on antibodies. So neuromyelitis optica is one where we do have an aquaporin 4 antibody that can let us know that is the diagnosis. A lot of kids in particular don't actually have positivity for that and can still be diagnosed with NMO. A newer discovery, I should say relatively newer, is this presence of anti-myelin oligodendrocyte glycoprotein, LOG, antibodies, is associated with several of these conditions and is helping us start to understand better and even predict the possible rate of relapse. So I didn't point it out earlier, but in the table that I showed you, it listed chronic or monophasic. So that was something we used to look at, or still do look at, with our patients. Having this positive antibody can increase the risk, or does increase the risk for recurrence. So we'll talk more about that as we get into this. So I could spend this entire hour talking about neuropsychological outcomes on demyelinating disorders, but I won't do that. I will say that there is a great review article that two of our PhD students, Alex Tan and Cole Haig, worked on during their time at UT Southwestern and published. The spoiler alert, though, is that all groups are at risk, okay, for cognitive, psychosocial, quality of life problems. And we have research to show that for every single group. We'll talk a little bit more about a condition restricted to the spinal cord and some things that we've learned about that in the area of neuropsychology. But there are no established cognitive phenotypes or expected trajectories. But there are a lot of factors to consider. And this goes back to the slide I showed early on, that it's all about the person in front of you and how clinically these things are showing up and how the symptoms affect them in daily life. There are some areas really vulnerable, but there are many of them in demyelinating disorders. I'll point out processing speed, and I'll mention multiple sclerosis. This is a really common one, really across the lifespan, not just in kids, but also in adults in that literature. Language pops up for kids with MS in terms of looking at cognition. This is something that we don't see in the adult literature, but it makes sense if you think about that the brain is developing and is having a hit from something like multiple sclerosis. So we really want to pay attention to those kind of critical periods of time where the brain is developing and how having a demyelinating event on the brain could impact not only development right then, but in terms of the trajectory of things. So these are some of those factors to consider. We do have some research that shows that earlier age at onset can be a particular risk factor. And I've just mentioned that, talking about critical periods. The time since onset, so how long has this person lived with this maybe recurring disorder, or even had the chance to kind of grow into difficulties. And I'll show you an image of that. Number of attacks or relapses is really important. So how many times was the brain impacted? Sleep and fatigue, I think I've already mentioned, are big factors in demyelinating disorders. In MS, fatigue is described as the most debilitating symptom of the disorder. And then, of course, we want to know how were they doing before, and any other risk factors that they might bring, maybe a genetic history for dyslexia or something along those lines. So if you think about the way that the brain develops for kids in particular, our attention and executive systems, frontal systems are most at risk. I kind of joke with trainees sometimes, if you're ever taking a multiple choice test and they ask what's, the most vulnerable area of function, this would be a great answer with kids, probably in almost any condition that we work on that's impacting the brain. And then really important to mention is that neuropsych problems may or may not be apparent in early stages. So if we have a new diagnosis, they come to clinic, they complete my screening evaluation, or I do a full evaluation and they look pretty good. That's a great thing. And we've documented that. We have a baseline for future comparison, but we also really want to watch them very carefully for this reason. So if someone has an injury to the brain, let's say early on, and at the bottom, it's age 0 to 18 cognitive skill listed here, you can see the typical development might go in a diagonal line. But if we've had some change to the brain, we've altered development, altered that trajectory, you can see a gap widen over time. So this is actually a reason that our neurologist will say, I'm going to discharge you from the clinic, but you're not allowed to be discharged from Dr. Harder or neuropsychology, because we want to see you develop more and get into those middle school years and really see how they respond to the increased environmental challenges that we all know are there. So this is something we always keep in mind, and we talk to families about as well. And we really want to emphasize any interventions that we keep those rolling and keep those in place to make sure that we keep them as close to this line as we can with their development. Other factors to consider, certainly disparities in disability accumulation. So our adult literature in MS has identified Black and Hispanic patients with MS would accumulate greater disability than white patients. But as we've studied this more and started to really zoom in on social determinants of health, we see that Black race and Hispanic ethnicity were not significantly associated with disability status when accounting for those social determinants of health and neighborhood level indicators of social conditions. So I think that's a really important point. And late last year, an article came out, really one of our first in pediatric MS or demyelinating diseases, that looked at both univariate and multivariate models. And what was interesting is they see associations in race, ethnicity, parent education, and so forth with brain MRI lesion volumes. But when you put that all into one model, a multivariate model, the only thing that remained was public health insurance, and that being a proxy for household income. So I thought that was a really interesting paper, and we certainly need more research in this area. Other factors to consider, so many things. Even prior to COVID, we were very aware, always thinking about how much missed instruction is there? When we, as neuropsychologists, might look at a learning disability or if there is the presence of a learning disability, we have to understand if they've had opportunities to learn. And so thinking about, especially after COVID in that era, what did they miss? What instruction may have been missed? And there's a great book on that from 2024 that talks about this exactly. But our patients do require formal school supports. And this is something we are mindful of in our multidisciplinary clinic and have great partners in school services for this reason. The other thing I've mentioned is that symptoms are often overlapping. When we looked at fatigue, emotional functioning, and executive dysfunction in pediatric MS, we saw that there were some associations here. So more mood symptoms and more fatigue were associated with poor performance on our measures of executive function. So I think it's really critical that we're all thinking about the ways that these symptoms overlap and that they're associated. One thing I say to families is, if we can, and there is research to support this, if we can pick a priority or two and address that, we may actually see improvements in other areas. I would love to see more research on this in children, but there are papers in the adult population that show that that is the case, that if we address one thing, we might see improvements, or we do see improvements in other areas. So a quick summary here before we talk about multidisciplinary care. I hope that you're taking away no one size fits all here. The diseases themselves are unique in terms of where they are acting in the central nervous system. So it does help to study groups of people. It's really important to think about that individual in your clinic, which I think we all do a great job of. There are many opportunities to intervene. And so another thing we talk about is what is the most distressing and what is interfering the most. And that can lead to setting those priorities I mentioned. It can be really overwhelming to have a long list of things to follow up on and a long list of recommendations. So we pick a couple and we see if that doesn't help in the overall for our kids. All right, moving into multidisciplinary care. And I just want to give a sample of the kinds of things that we see in the clinic. And I hope as you think about each of these cases, which we're not going to delve into more than the little blurbs here, that you'll think about all of the things that they're presenting with and why having a team of experts is really critical. So a 5-year-old who's about to start kindergarten, a wheelchair user with attention and fine motor difficulties, and the diagnosis was at 4 months, right? So we are helping prepare this kiddo to start school. A 7-year-old who was diagnosed about 4 years ago, who had acute disseminated encephalomyelitis, was positive for the MOG antibody we talked about. So there was some risk for recurrence. Having some school problems with language, reading, handwriting, and attention, and also facing barriers to getting school services. This actually comes up because a lot of schools have never heard of ADEM or the conditions that we treat. So that's where we come in. A patient with neuromyelitis optica who was 10 at onset. So this tells you it happened recently because they're 10 years old at our clinic and adapting after a hospitalization and inpatient rehab, where they had experienced motor and vision changes. And they're adapting to a new rehab schedule and anticipating a return to school. So thinking about how am I going to do all these therapies and still participate in school? And last, a 16-year-old who was diagnosed a year ago, just adapting to this new diagnosis. I have a chronic medical condition, multiple sclerosis. I'm thinking about college, I'm thinking about my future, but what does it mean that I have MS? How is that going to change the trajectory? Having some insurance barriers. They get monthly infusions, but are having trouble getting those paid for, and they're very expensive. Problems with processing speed, fine motor functioning, and some mood symptoms. So a lot going on really on this whole slide. And so that brings us to the multidisciplinary model of care for these kids. And I think you can already appreciate how valuable it will be to have a team of people working together. Just a quick word on multidisciplinary. This is relatively new in the overall history of medicine. And so it's this team approach. This can be to providing care, intervention, evaluation, or research. We do a lot of those things in our clinic. I really appreciate the point that implementation can look different, certainly across different organizations, but even within one organization. I can think of multiple examples at Children's in Dallas where we just do it a little different. And so that can be because it's evidence-based to do that. It could be based on patient need, it could be on resources available. So I know we started out a certain way and we have grown into what we are today. So models may vary. There's no one way to do it. What I think is very exciting to see in the research is that multidisciplinary care has been associated with improved outcomes, with improved diagnosis, quality of care, and increased satisfaction. And notice, it's not just for the patients. That increased satisfaction is also seen across providers. I can attest to that. It's probably one of my favorite things I get to do every week is go to our clinic. Additional benefits that are often highlighted about this model, it's convenient. We'll talk more about that for our clinic. Addresses an array of symptoms. You saw all the different things on the slide about patients. So we're able to address all of those things. If I can't address something, I know who on the team can help with that. It's time and cost efficient. Families are not running from different appointments or having to travel great distances for one appointment and then the next week do the same thing, miss work and school. I think a huge piece of this is care coordination. We have a nurse, we call her like our boss. She really runs everything and she directs us. Which family do we need to reach out to during the week, or what are the needs that are ongoing between clinics? So she is really that point of contact. I used to hand out my card and now I say Denise knows how to find me. So, because that's easier, I think, for families, just one point of contact. So with team-based care, it's important to have established goals, a unified purpose. One of my favorite points is that our patient is the MVP of this team. So they're an actual member of the team and helping us know what they need from us. We're treating the whole person to address all of the problems that they present. So absolutely, the reason we started there was we needed a neurologist specialized in demyelinating disorders, and we're treating those medical symptoms. We're trying to hold off attacks. And then as you'll see, we have a whole group of people that add in to the care around that diagnosis. Having a consistent team, I think, is really critical. We do have a couple of a service or two where we have some rotating folks, but it's usually only 2 people and they know demyelinating disorders really well. So we want to make sure we keep that expertise in the room with families. And then communicating and collaborating across providers so that, we're all in one room. We're talking about what Johnny needs today at clinic, and we're going to share that cohesive plan before they leave. And then also something that has provided a richness for me as a professional is this openness to learn from each other. We are still, after almost 17 years, still asking each other questions about the work that we're doing and our, the lens that we bring. And it's really wonderful. There is no dumb question in our clinic. We feel very comfortable to ask anything. So our clinic opened in 2009. I had just started working at Children's. I had the huge privilege of being a founding member and now co-direct this program with our neurologist. So you can see neurology, neuropsychology, nursing. We have 2 nurses, a clinical and research nurse. We have social work, school services. They serve as a bridge, a liaison between the hospital and the schools, a vision assessment specialist, and then physical medicine and rehab. So we are really lucky to have this great team. Again, it's kind of grown and changed over the years. I listed a couple of other areas: neuro-ophthalmology, radiology, urology, and surgery. Okay, more than a couple. And these are our colleagues on speed dial. So we can call them and get our patients plugged in as needed. We can add on a visit while they're with us so that they can be seen for whatever their need is. And I just did a quick snapshot of the roles by discipline, but I'll highlight a few things. I'm going to get into the role of neuropsychology. So I mentioned neurology leads this. They're focused on our diagnosis and treatment. And our neurologists are awesome at knowing what all of their specialists do and what specialists outside of our group do. So they are just great at directing care wherever it needs to go based on that patient and the day that they come and see us. I mentioned Denise, our nurse, just really runs the whole show. She's directing traffic. We have a huge board with our names and dots, magnets that we put to let others know we're in the room. And who's next, who's going into this room next. And if we didn't have that, we would be sunk. It would be really difficult. We also have a nurse who is consenting patients for our biorepository and for other studies that we have going on, which is a wonderful thing to have in place. Our social worker, I could, make many slides on all the things that she does. She does lead our transition programming. We've designed a transition planning program for those patients starting age 13, getting ready in many years to move to the adult side. She monitors the social determinants of health, provides resources to families, assists with lodging when they're traveling. You'll see in a moment that kids are coming from all over. And then provides referral information based on where they live and their insurance. Mentioned school services already. They do a great job. They've actually developed these one-page handouts on each of our disorders so that it gives a quick snapshot for schools of what ADEM is, how it might show up in a classroom, what are some recommendations that may help students. So that's great. Their education and advocacy is absolutely vital. We have a vision assessment specialist doing the OCT evaluations, and then our physical and medicine rehab directing needs for rehabilitation therapies and monitoring progress. So a little bit more about neuropsychology. Lots of hats here in this clinic. I mentioned leadership before, but also clinical care is the focus. So a lot of consultation, triage, evaluation services, follow-up, and treatment planning. I'll say more about that in a moment. And one of my favorite things, clinical and research training. So bringing trainees along for all of it, and then our research. So this is just a quick snapshot in blue of some of the things we provide in the clinic. So I'm consulting with every patient that's coming through. And then based on that consultation, we make a determination about conducting a screening evaluation right then and there at the clinic. 45 minutes to an hour is what it takes. Based on that screening, we decide, do you need a full evaluation, which would take 8+ hours? So we want to be really sure that we know who needs that evaluation. Or we might say, no further testing, but we're going to monitor you over time. I can also determine from a consultation, you know what, we need the full evaluation. I've learned enough that I know we're just going to go for that, save an extra step at clinic. And of course, we're doing ongoing surveillance. These are kids that are following up with us for years. I have watched one of my first patients was 6, and he is now a college graduate. So I get to really watch them grow. And with that, their needs change so much. And so we're right there to respond to that. This just alludes to what I talked about before, where we want to be really sure we know who needs this comprehensive evaluation. It is an investment in time and money and other resources. So we want to think about a model that looks like this. This is a big discussion in our field, that we're kind of monitoring everyone and then doing some targeted brief evaluations to ultimately decide if we need that evaluation. For those who might be interested in the battery, especially the neuropsychologists here, these are the areas, the domains that we're focused on. This was all designed knowing what the vulnerabilities are in demyelinating disorders. And so again, this is a battery that takes about 45 to 60 minutes. We do not want parents to be bored, so we add some parent ratings for them. And they're a wealth of information as the true experts on their kids. So we've reached my favorite part of this presentation, and this is where all the magic happens, again, in our multidisciplinary visits. But it's more than that. I think it's when you bring a group of people together who are focused on the same patient population, share an interest, and are just very curious about these populations of rare disorders, and how can we learn more and how can we move the field forward. So when we think about our clinic, and I say this to parents, you know, they're sitting in these clinic rooms and waiting for the next person. And we try to give them things to keep them entertained, and we try to move quickly. But sometimes they'll be there for 3 hours. And I just let them know, we actually designed this on purpose as a one-stop shop to keep you from the, you know, having to manage all these individual appointments and having to travel and find lodging each time, missing work, missing school. So also, we're supporting program development. I'm going to expand on probably all of these. But again, when we come together, we can really intentionally design programs for our patients and their needs. We advance the field through our research. One thing we do that is just a lot of fun is we contribute to and promote community engagement for those with rare disorders. I meet so many people that I will never see at Children's through a family camp that we go to and volunteer for, or you know, a fundraiser walk and roll that we have. There's different things that we do. And then lastly, we're enhancing faculty and professional growth in pursuit of goals. So this was a clinic that fell on Halloween, and so we don't dress up every time. I wish we did, though. That would be great. So as a neuropsychologist, I was relatively new to Children's, and I show up to a clinic to see kids. I'm told I'm going to see kids with demyelinating disorders. I'm like, great. I saw some of them on internship and fellowship. And I get to coordinate care with all of these brilliant specialists, right? So in doing that and coming together, we build programs, and we have earned a designation as a National MS Society Comprehensive Care Center, and now an SRNA Center of Excellence. So that's what we're able to do when we all come together and intentionally design the programs. I mentioned the transition program when talking about social work. We've also developed transition planning for our kids, again, starting at age 13, so that they're in a good place. And we've thought of all the things and addressed the barriers that we hope most of the things before they go off to see adult providers. I mentioned community engagement. This is us at some of our events. This was a camp put on by the MS Society to the left above. This was the SRNA camp. There's something called Messy Games. It got a lot messier than that. But we were in teams and getting ready for that. We had a fundraiser here, I believe, for the MS Society. There's Bike MS. I think a lot of people have heard of that. So getting involved and getting out into the community is a great thing. We do see our patient families there, but we also meet a lot of people we would not have known before. Dr. Whitaker mentioned telehealth services. So back years prior to the pandemic, we were aware that our patients were coming from so many different places to see us, both across the country and internationally, again, because we were treating rare disorders. And at the time, there were just a couple of centers, but that thankfully has changed. And we've seen a great multiplying of multidisciplinary programs around the country, which is very exciting. So our goal here was to promote access to specialty care, but we wanted to learn about what tools we might have if we were to leverage today's technology. And all of this will sound really funny because telehealth is everywhere these days. But what we knew at the time is there were no published teleneuropsychology studies in pediatric cohorts. I showed you a list of tests that we use in the clinic. Those are standardized. We're very serious about standardized tests. And if we're going to change something about it, we need research to say that we can do that. The other thing that no one had studied, even the adult folks that were studying teleneuropsych, was how would this go if we tested them at home? And that's a scary thought when you think about all the distractions we have in our homes, right? So we wanted to examine home base specifically. And then we wanted to know what caregivers and patients thought about this experience. So we looked at satisfaction. So very briefly, we looked at feasibility. We looked to see were there differences in results when we tested in a traditional in-person scenario or over video, like a kind of like Zoom. We didn't use Zoom, but and then we looked at satisfaction. So there were no, just the short version, there were no differences. It was feasible. And we saw a lot of great satisfaction data as well. We were able to publish this at the beginning of 2020. And so we know that timing was great to be able to have something to reassure us as providers that if we did work with our kids over video, that we did have some evidence to support that. Doesn't mean this is the end all be all. We need many more studies like this to better understand that. So we've talked about the coordinated clinical care. We just gave an example of research. There are many more examples of research. I'm going to highlight a few things. Another thing that happens very naturally when you bring a team of people together in a clinic is we start to ask research questions. When I'm sitting with the family, they give me ideas about research. Not that they say, Dr. Harder, here's an idea for your study. They're telling me things that maybe I just heard from 3 other patients. And I think, oh, this could be a hypothesis to explore. We do the same thing as, providers in our touchdown space where we're all working and conversing about everything. So, and then when we do learn something, we can immediately have it inform what we're doing with our patients, and we can even share those results. One thing I love is to share results with patients of our studies when they've been a participant or even when they haven't, but I like to let them know what they're contributing to. And then as we didn't know much at all when we first opened about neuropsych outcomes in rare disorders, I came into the clinic thinking I couldn't wait to study MS and ADEM because look at the table, it affects the brain. I'm a neuropsychologist. I can see it on MRI. I want to know all about this. But what about our other groups, right? And so I thought, you know what, great control group, transverse myelitis, it's a demyelinating disorder impacting the CNS, but it's only in the spinal cord. So let's compare and use this as a control group. We were surprised, and we did a comparison with MS and TM. Yes, we saw some differences in cognition, but we also saw cognitive problems in TM. We also saw the same exact rate of school problems reported by each of these groups. And that was really eye-opening. It's something I love to tell others and to tell students is let your data surprise you. We think we know, we have a hypothesis, but I love it when my data shows me that, hey, this is maybe an area that deserves some attention. So we were able to kind of press pause on the first project we were working on, and we just directed our focus to cognitive functioning in pediatric TM and put this paper out. We saw higher rate of attention, memory, fine motor coordination, and we wondered, why this might be if this is a disorder restricted to the spinal cord. And so we had some questions remaining. What about the role of fatigue? Rates of fatigue were very high in our data. And what about brain-based pathology in TM that we're just not picking up on in traditional imaging techniques or those that we would use clinically? And this led us to fund this study that was looking at the brains of patients with TM, and we used sibling controls, very small sample sizes. And we actually were able to use this as a basis for a larger study using a 7T magnet, and we're analyzing that data right now. So I will say stay tuned on this. So the other thing that, we're positioned to respond to is when I walk into clinic and they tell me about this new thing. And we have a joke about this, that we walk in and there's just something new that we didn't know before. And now we have to go back and figure out our data and, what data we need to analyze. So when we were learning about this new antibody or this new condition, MOGAD, which as a reminder, can show up and typically shows up in these conditions or in association with them. And I'll mention that MOGAD is most common in children and most common in ADEM. And so we wanted to understand more about neuropsych outcomes with this. And I'm seeing some new literature that's really great, looking at the difference in monophasic MOGAD and recurring MOGAD. So I do see some more activity in the literature, which I appreciate. I didn't say this before, but MOG is a glycoprotein important in the myelination of nerves in the CNS. And I think we talked about the rest of this already. Okay, so in our sample size, which was just under, I think, 40, we looked at basically just as a descriptive analysis, percentages or frequencies of patients struggling in different areas that we test. So more than 30 had problems with fine motor, coordination, memory, and attention. And then greater than 20% in visual motor integration, auditory attention, working memory, processing speed, and verbal fluency. And almost half reported receiving educational support services. So the learning on MOGAD is ongoing. It's kind of the newest thing that we're trying to understand. So just to kind of wrap up this whole process here, when we learn new things, we publish them, we are able to access research funding, and we go out and share what we're learning through symposia, podcasts, webinars, both that are provider facing, others in our field, but also for patient and families. And I love, again, to share that information with them and what we're learning. I think maybe the best part is that we get to bring along our trainees. And so we are preparing our next generations of clinicians and researchers. You might recognize actually a couple of faces on here, Dr. Christopher. I had to add that. But these are, one is a dissertation I was chair for Alex Tan, and then we have other fabulous trainees presenting at meetings and symposia. So I think that's really one of the best parts of this work. And on that note, we're experiencing healthcare transformation. We mentioned multidisciplinary was a newer thing in the history of medicine, but you are seeing more of the team-based approach. There's an excellent article chapter about supervision and the future in neuropsychology that I pulled from, but you are seeing patient-centered model where we're treating the whole person. Neuropsychologists are really critical on so many teams, but I would highlight from demyelinating disorders for all of the things and all of the reasons that you saw today. And so also we have new training guidelines that were recently published for neuropsychology. And there is a competency now for interdisciplinary work, which I think is a critical component in this day and age. So that was very exciting to see. In summary, our patients with demyelinating disorders really show up with complex needs. Having a team to support them is really critical, and we've learned that. I think that we're promoting quality care while advancing the field and promoting community engagement with our stakeholders. We're doing all of that when we come together, but it's also creating this rich space for professional growth as well as teaching and training. And so for any of you seeing these patients, I threw some resources in here. There are some great organizations who really care about the same populations, many of them patient advocacy groups. This is my team in Dallas, so I want to acknowledge them. We have a lot of fun in addition to taking care of patients. And I had to also include my pet. So thank you for your time and attention. I'm happy to take any questions. Especially if you want to talk about my pets. During my visit, I'm going to be curious to hear about the work that you guys are doing in teams and specifically with demyelinating disorders. So I have a lot of questions for you. I don't know if there were any in the chat, but oh, I see. Yeah.
It's the cadence of your teams. I think one of the questions I have is how do you fill those slots, right? How do you get families to commit to I know it sounds great to us. You fill everything in one day, but we have families cancel and contract for families. So when you just kind of the cost and time for everyone, how do you justify it? How is your schedule?
That's such a great question. And I will say, and I didn't mention, we started as a once a month half day clinic. And now we are every Friday. I would say every Friday for the rest of my life is booked. With rare exception, if there's a conference, we wouldn't meet. But and we now have 3 neurologists. And so it's really busy. I actually am recommending that we get another neuropsychologist more involved. But so we are there weekly. Our show rate is pretty good. We do have an established relationship. I mean, once, of course, we have new patients, but once we establish with them, the show rate is pretty almost too good. I mean, sometimes it's like we are really struggling to get through and see everybody. So I do feel like it ends up being a good use of time. I am not the person that is routinely looking at the finances for it, but I am told that it is revenue generating, so that's a good thing and a critical thing to be thinking about. I hope I answered all the parts of your question. Yeah, and we can talk more too. Yeah.
There was a question on the chat about what is your opinion for the NIH toolbox, both in research and clinical study?
Yeah, good question too. Well, it's interesting. The NIH toolbox has come up for me and come across my radar through just kind of randomly here and there when I'm hearing about studies. It's only been very recently that I've been diving into that more. And it was actually for a different project, not related to demyelinating disorders. Some of the things I see I really like, and I was looking at some of the psychometrics and things. I love that, like the age range, the how quickly things go, that it's available. And I know for our purposes, we were looking at Spanish, so a lot of them available in Spanish, possibly other languages, I don't know. So I am very intrigued, and I am moving forward on a project where we are going to incorporate those measures. So, but I'm excited to learn more. So if during this visit, anyone could tell me more, I'll take it.
Okay, yes. What are some what are the most common comorbidities that you see with demyelinating disorders in children? So like ADHD versus other learning disabilities or something?
Yes. Ooh, I like this question. So one thing we are noticing a lot of, and I would love to compare notes with others, we're seeing a lot of reading disorders, dyslexia, like more of that language-based difficulty. ADHD is not uncommon for our kids. I think we see depression, and I know that in adults, we know that that's very commonly associated with MS, and that's one area we tend to see more mood-related symptoms. Those are some of the ones that pop up. Anxiety comes up quite a bit as well. So yeah, it's a great question. We've been talking about looking at that data, especially with the reading disability. And we've been trying to formulate hypotheses about how all of this might relate, like thinking of the brain-based changes and how that could tie in. So, yeah.
Sorry, follow-up question, and then do you see any specific disorders with where the lesions are with any specific locations?
I think that's where we're wanting to go with looking at the reading piece, but nothing specific so far. That imaging study I mentioned that we're analyzing that data now, I hope might shed some light on that and get a little bit more specific in the correlates, because we did do a pretty nice size neuropsych battery in conjunction with that that study. Yeah. And it was longitudinal as well. Just yeah. So more to come. I hope.
There's another question on the chat about and what percentage of your interdisciplinary aesthetic patients already have an established diagnosis coming to you versus wow?
Yeah. So a number of them get the diagnosis on inpatient, and it's often at our institution, not always. We also have quite a few that are coming in for a second opinion or kind of to confirm something. So when I'm picturing the board of our that I mentioned, our dry erase board, most of them are going to have a diagnosis listed, or and then when we truly don't know and they're there for a workup, there's a question mark. So I would say the vast majority though have a diagnosis, and many came from our inpatient setting, inpatient rehab. Yeah, good question. And our neurologists don't always agree, especially, you know, for outside, but many times they do. Yeah. So we do a lot of reviewing the outside reference too. Thank you for having me.
We want to present you with our Lana Kaplan Neuroscience Award. Thank you.